Xin chào tất cả các bạn. Hôm nay chúng ta sẽ được cô Caroline Becker là giảng viên y khoa tại trường Đại học Harvard trình bày về các rối loạn canxi và tuyến cản giáp. Cô sẽ trình bày các tình huống lâm sàng và từ đó rút ra các bài học về các rối loạn như là suy tuyến cản giáp, tăng canxi máu không liên quan đến tuyến cản giáp, cường cản giáp nguyên phát cũng như cường cản giáp thứ phát. Đồng thời, cô cũng đưa ra các cách để giúp chúng ta chẩn đoán và tiếp cận trong các trường hợp khác nhau. Ok, chúng ta cùng bắt đầu nhé.
My name is Carolyn Becker, and I'm going to present the calcium and parathyroid disorders in the next half hour. And these are my disclosures, writing for up to date. So I'd like to begin to make sure we're all on the same page in terms of calcium and parathyroid. And I like this nomogram, which shows calcium in millimoles per liter here on the x-axis, going from low calcium to high calcium. And parathyroid hormone, PTH, on the y-axis going from low to high. And the disorders we're going to talk about are ones outside of the normal range here. And one is going to be hypoparathyroidism, where calcium and PTH are low. We're also going to discuss non-PTH mediated hypercalcemia, where calcium is high, but again, PTH is low. The biggest category that you're going to see in your practice are cases of primary hyperparathyroidism, where both the calcium is high and the PTH is high. But I'd also note there's a lot of overlap. Calcium can be sometimes in the normal range with a high PTH, or calcium can be high with an inappropriately normal but not suppressed PTH. And the final category is secondary hyperpara, in which the calcium is low or low normal, but the PTH is high. And I'd also like to just review the actions of PTH. So let's take, for example, an adenoma secreting too much PTH. What does that do? First of all, PTH acts on the bone, where it increases bone resorption. This releases increased levels of calcium and phosphate into the circulation. PTH also has direct effects on the kidney, and it has multiple actions, including reabsorption of calcium from the renal tubule, increasing serum calcium. It is phosphaturic, causing increased phosphate into the urine. And the third action is on the 1-alpha hydroxylase enzyme, which converts 25-hydroxy-D into the active form of 1,25-dihydroxy-D, that in turn acts on the gut to increase the gut absorption of calcium and phosphate. So let's start with a case. This is a 65-year-old woman with hypertension in stage 3 CKD, who you find in clinic has hypercalcemia. Her serum calciums range from 10.6 to 11 milligrams per deciliter, mildly elevated, and intact PTH is 90, and a repeat is 98 picograms per ml. Again, normal up to 65, so this is high. Her creatinine is 1.4 milligrams per deciliter, and her estimated GFR is 39 mils per minute, where normal is up to 60. Her 25-hydroxy-D is normal at 30, and her urinary calcium excretion is in the normal range at 188 milligrams in a good collection of urine. She's on lisinopril for her hypertension. You get a DEXA, including the 1/3 distal radius, which shows her lowest T-score is -1.8 at the femoral neck. She denies any symptoms of hypercalcemia. She's never had a fracture. She's never had a kidney stone. You perform a neck ultrasound, which shows nothing abnormal, and a sestamibi parathyroid scan, which is non-localizing. So the first question for you is, which of the following is the best next step? A, would you treat her with cinacalcet? B, would you send her for a 4-gland parathyroid exploration? C, would you measure her serum 125-dihydroxyvitamin D? Or D, would you repeat her serum calcium and PTH in 6 months? A little more time here. Okay. So most of you are picking D, repeat the serum calcium in 6 months. Some of you are picking C, measure the 125. And a minority of you are picking send for the 4-gland exploration, which is actually the correct answer. So this is good. I always like to be able to teach you something. And I think this is an important point. So let's go over this case. This is a lady with really asymptomatic primary hyperparathyroidism, mild. But I'm telling you that the correct answer is actually to send her for surgery. So A, cinecalcet, which few of you picked, can be used as a bridge to surgery in medically unstable patients with primary hyperpara. But this is a stable, healthy patient who meets criteria for surgery and agrees to surgery. So there's no role for cinecalcet, a calcimimetic here. Why does she meet criteria for surgery? It's due to her low GFR. She meets the criteria based on that alone. Therefore, you need to first look for an adenoma, which was done and was negative. And if that is so, the next step is to send her to surgery for a 4-gland exploration to find the cause of her primary hyperpara. The measurement of 125 dihydroxyvitamin D, it's something we sometimes do in patients with CKD when we're trying to figure out is this primary or secondary hyperpara. But in this case, she clearly has primary hyperpara with a high calcium, high PTH, and CKD. So this is not necessary. Repeating calcium and PTH, which a lot of you picked, would be appropriate if she says, I'm not going to have surgery, I refuse, or she fails a surgical cure. So an important teaching point. Let's go over the evaluation of asymptomatic primary hyperpara. It's important to check all of these things: calcium, phos, alk phos, renal function, intact PTH, and 25D. A 24-hour urine for calcium and creatinine excretion, and then you can measure the calcium creatinine clearance ratio, which is a simple formula. This is mainly useful in young patients presenting with primary hyperpara, where you want to make sure they don't have familial hypercalcemic hypocalciuria, but that's pretty rare in a patient presenting at age 60 who would have been hypercalcemic her whole life. Getting a DEXA is another important part of the evaluation of asymptomatic primary hyperpara and was done in this patient. Important to include the 1/3 distal radius, since that's the bone most affected by high PTH. Other things to consider are vertebral spine imaging by X-ray or vertebral fracture assessment on DEXA to see if indeed she has an asymptomatic fracture of her spine, a symptom of osteoporosis. A stone risk assessment may be useful if she has high urinary calcium, or abdominal imaging with a KUB or even a CT or ultrasound to look for silent stone disease, which would be another indication for surgery. Once you've done this, here are the surgical criteria for asymptomatic primary hyperpara: a serum calcium greater than 1 milligram per deciliter above normal, a DEXA T-score of -2.5 or lower at any site, spine, hip, or wrist, a creatinine clearance less than 60 cc per minute, age less than 50. Other criteria can be if you find that fracture on imaging, or she has high stone risk, or stones on imaging. So in this patient, it was the creatinine clearance being low, the low GFR, that gives you the criterion for surgery. Due to this, she needs surgery, and since nothing localized, the correct answer for her is a 4-gland parathyroid exploration. Now, what if she refuses surgery? What about medical management of primary hyperpara? Well, for patients who have osteoporosis and primary hyperpara, there are data showing that bisphosphonates can help slow or stop the bone loss. So can estrogens, so can SERMs, such as raloxifene or Avista. Cinacalcet, Sensipar, can be used for patients with symptomatic hypercalcemia who refused or cannot go through surgery, but it will not improve their bones. It does not help their osteoporosis if they have osteoporosis. Also important in the medical management of primary hyperpara, do not calcium restrict these patients. They will just have a higher PTH and lose more bone. We maintain calcium intake at a moderate level, 800 to 1,000 milligrams of elemental calcium per day, and we keep the vitamin D up to about 30 nanograms per ml to prevent secondary hyperpara, again, with more bone loss and higher risk for fractures. Now, there is a differential diagnosis of primary hyperpara that I just want to quickly go through. Most cases are what we call sporadic, not genetic, not hereditary, over 90% of cases. Some are drug-induced, particularly with lithium or thiazides. But I do want to call your attention that 10% of patients with primary hyperpara have a genetic or hereditary form. Most important not to miss are MEN1 patients. These often present young with kidney stones, primary hyperpara, and are at risk for pituitary and pancreatic lesions and other diseases, MEN2A, and these others are more rare, but always think about these in a younger person or someone who presents with atypical primary hyperpara, more than one nodule, recurrent hyperpara, etc. So let's move on to another case. This is a 64-year-old woman who has a DEXA after falling and breaking her arm, her right humerus. This shows osteopenia at the spine, but she has osteoporosis at the hip sites. You do a workup which shows her total and ionized calcium levels are normal, but PTH comes back 3 different occasions high. With normal up to 65, she has high levels on 3 different days. Her creatinine is normal, GFR is normal, 25D, phosphate, and 24-hour urine calcium excretions are all normal. She's not on lithium or hydrochlorothiazide. She feels completely well other than getting over her broken arm. What is the most likely diagnosis? A, secondary hyperparathyroidism, B, normocalcemic hyperparathyroidism, C, renal leak hypercalciuria, or D, occult malabsorption. And I'll let you take a few seconds to vote here. Okay, so it looks like the big choice is between normocalcemic hyperparathyroidism and secondary hyperparathyroidism. And most of you did get this correct. This is a description of the entity we call normocalcemic hyperparathyroidism. And I'd like to go over some teaching points with you about this condition that we're often seen in our osteoporosis clinics when we work up people after a fracture and check their PTH. This is when you have normal serum total and ionized calcium, but elevated PTH on at least 2 occasions. This lady had 3 elevated PTH levels. This is a diagnosis of exclusion. You cannot make this diagnosis if the patient has CKD, if they are on these drugs, including if they've been treated with bisphosphonates or denosumab, which will raise PTH, if they have malabsorption, such as celiac disease, if they have hypercalciuria, or if they have vitamin D deficiency. So these have to be ruled out before you can make the diagnosis of normocalcemic hypercalcemia, and those all were ruled out in our patient. So now that you know what she has, what would be your best next step? A, would you do parathyroid imaging studies? B, would you give her cinacalcet? C, would you check calcitriol? Or D, would you recheck serum calcium and PTH in 1 year? Okay, most of you, 92%, are getting the correct answer, which is parathyroid imaging studies. Very good. So let's go over this. This is a woman who just broke her arm and has osteoporosis. So if she has primary hyperpara, she would be a candidate for surgery. And in that case, if she agrees to surgery, the next step is parathyroid imaging. And that's to allow, hopefully, minimally invasive parathyroidectomy rather than a 4-gland excision or a 4-gland exploration. Cinacalcet lowers the PTH but does not improve her bone density, so that's not going to help this lady with osteoporosis. Calcitriol, if given as a treatment, will lower PTH and potentially increase her serum calcium, but is not a definitive therapy. I'm sorry, I should have said give her calcitriol, not check calcitriol. But that will not be definitive. And you can recheck calcium and PTH if she refuses surgery. But with her osteoporosis, she is actually a candidate for surgery. And so you want to go to imaging. We have 2 major modalities. One is a sestamibi scan, which lights up the positive adenoma. It's a radionuclide scan. The other is a neck ultrasound. And both of these depend on the operator and how well they do at how many of these they see and how good they are at locating these things, which can be small and sometimes difficult to find. So we talked about sporadic primary hyperpara. 80 to 85% of adenomas are sporadic, but 10 to 15% can be hyperplastic. This is usually in chronic kidney disease, end-stage renal disease, sometimes with lithium. And a very small percentage can have multiple adenomas. Thankfully, very low percentage are cancer, parathyroid carcinoma. But it turns out that patients with normocalcemic primary hyperpara are different than classic hypercalcemic primary hyperpara. All of the localization studies that we use have lower sensitivity in finding the adenomas in normocalcemic disease compared to classic primary hyperpara. And in fact, at surgery, multi-gland involvement is more common in the normocalcemic form of this disease compared to classic primary hyperpara. However, the studies have shown that when you take a patient like our patient and operate and successfully remove the 1 or more glands that are causing this condition, there are improvements that are significant in bone density and even in nephrolithiasis if that were an issue. And this is similar to classic primary hyperpara. So how do we monitor patients with this normocalcemic primary hyperpara that we're seeing more and more often? Get calcium and PTH annually, DEXA every 1 to 2 years. Now, like our patient, if they already have had a fracture or significant low BMD with osteoporosis, or they presented with kidney stone or nephrocalcinosis, they go to surgery just like a primary hyperpara with hypercalcemia. Or if they don't have this, but you watch them and they progress to hypercalcemic primary hyperpara, you follow the guidelines for surgery with those patients. So in our case, this patient had to go to surgery, but she needed the imaging studies first. Let's move on to our third case. This is a 55-year-old woman with symptomatic hypercalcemia over several months. Bilateral breast implants was her only surgery. She's a former bodybuilder, doesn't do any drugs, alcohol, or cigarettes. On exam, she is sick, she's dehydrated, lethargic. She does have bilateral breast implants and firm non-tender nodularity over her upper arms, buttocks, hips, and thighs. Chest x-ray is negative for any infiltrates. Her calcium is high, her creatinine is high, PTH undetectable, vitamin D is low, and her 125 dihydroxy vitamin D is high. So what would be the best next step for this patient? Would you A, measure PTHrP, B, biopsy one of the nodular masses, C, do a CT scan of her chest, abdomen, or pelvis, or D, a radionuclide bone scan? I think many of you are going for the CT scan of the chest, abdomen, and pelvis, others for a PTHrP. So for sake of time, I'm going to go on here. The correct answer is actually to do a biopsy of one of the masses, though a CT scan of her chest, abdomen, and pelvis wouldn't be wrong, but would not give the answer, the correct answer to what is going on with her. So let's discuss this interesting case. The key finding on her labs, if you look back, was she had an elevated 125 dihydroxy vitamin D level in the setting of hypercalcemia and undetectable PTH. This is the clue to her diagnosis. This 125 level should be low, not high, and that's the key. So what causes that we'll go through, but the biopsy of one of her masses that you felt on exam revealed silicone-induced granulomata with activated macrophages secreting 125D, and this is a case of a foreign body reaction and hypercalcemia. Here, let me just show you with a case of sarcoid, another granulomatous disease, how this works. Here, the activated sarcoid granuloma in the lungs has the 1-alpha hydroxylase enzyme, just like the kidneys, and converts 25 to 125D. And that in turn suppresses PTH, activates bone resorption, releases calcium and phos from bone, acts on the kidneys to increase urinary calcium absorption, and also acts on the, does not increase calcium absorption, but increases urinary calcium excretion, leading to kidney stones and hypercalciuria, and also increases gut absorption of calcium. So this is what happened in this patient. She had multiple silicone implants. She was a bodybuilder, and this was an MRI of her buttocks and thighs. And this is part of what we look for in non-PTH mediated hypercalcemia, part of the what I like to call the absorptive hypercalcemic, which can be from excess exogenous vitamin D, such as vitamin D intoxication. In this case, it's excess endogenous vitamin D from granulomatous. granulomatous disease. You can also see this in lymphomas and renal cell carcinoma, or excess calcium in milk alkali syndrome versus resorptive hypercalcemia, multiple myeloma being the big one here, malignant diseases with PTHrP-mediated squamous cell, CA's renal cell, breast cancer, which is both osteolytic and secretes PTHrP, and these other entities. The workup for non-PTH-mediated hypercalcemia, history and physical exam are the key. Other things you can always think of checking: SPEP, UPEP, the vitamin D levels, both 25 and 125D are useful in this entity. PTHrP, usually by the time you get it back, you already have the answer, and there are many other things you can check. So let's quickly go to case 4, an 82-year-old woman with paresthesias, muscle twitching, 2 recent falls. She has CHF and severe esophagitis. She has furosemide and recently started omeprazole, 40 milligrams a day. She has positive Schwastik and Trousseau sign, and her labs show a calcium that's low, 6.8. Albumin is normal, renal function is normal, PTH is normal at 30, and her ALK phos is normal. So your last question: which lab test is most likely to explain her hypocalcemia? Would it be serum magnesium, 25D, 125D, or a TTG antibody for celiac disease? For sake of time, I'll just give you a few moments, and all of you have, the 8 of you who voted got it right, so I'll stop with success. And the answer is magnesium. This is a woman presenting with near tetany and hypocalcemia with hypoparathyroidism. In the setting of severe symptomatic hypocalcemia, PTH should be very high, not normal, but it turns out PTH is magnesium dependent. This is a lady on diuretics and PPIs, both of which can lead to mag depletion and functional hypopara. And just to review these symptoms of hypocalcemia, she had Schwastik sign, she had Trousseau sign with the carpal spasm. You can get prolonged QT interval, as well as severe laryngospasm, bronchospasm, and death. So very serious. And most of the time, this is from destruction of the parathyroids from surgery. There can be infiltrative disorders shown here, a Kaiser-Fleischer ring from Wilson's disease and copper deposition, or autoimmune disease. But in this case, this is a case of hypomagnesemia, a reversible cause of hypopara. And with that, I am going to thank you for your attention.
Vâng, bài học đến đây đã kết thúc. Cảm ơn các bạn đã chú ý lắng nghe. Nhớ like, share và subscribe để theo dõi các bài học tiếp theo. Xin chào và hẹn gặp lại.